We kindly request all the speakers to adhere strictly to the time limits to ensure smooth flow of the sessions.
Good morning, everyone. The navigating the perioperative fluid maze requires a strategy, precision, and evidence-based, not a guesswork. My topic involves in the following headings: introduction of perioperative fluid management, definition, some basic physiology, principles involved in fluid challenge, evolution of fluid management, myths and facts, monitoring technique involves, and current strategies of fluid management. Introduction. The fluid management is a critical aspect of perioperative care. It plays a vital role in optimizing patients' outcome and reducing the risk of complications. The effective fluid management involves a comprehensive understanding of patient's fluid status, surgical procedure, and risk associated with the fluid balance. Importance of the fluid management: it maintains a hemodynamic stability by preserving the circulating volume in cardiac output, hence prevents complications like hypovolemia, hyperolemia during anesthesia. It also ensures adequate tissue perfusion and oxygenation. The sufficient intravascular volume avoids organ hyperperfusion and acute kidney injury. It balances the fluid shifts and losses and compensates for the blood losses, insensible losses, and third space shifts, which is essential during major surgeries. It also prevents some of the complications of perioperative fluid management like pulmonary edema, poor wound healing, and coagulopathy. It also optimizes postoperative recovery. It balances the fluid, reduces postoperative nausea, vomiting, paralytic ileus, and hospital stay, which is a part of enhanced recovery after surgery protocol. Few definitions. The preoperative phase, the fluid assessment and correction before surgery. The goal is to correct the dehydration and electrolyte imbalances preoperatively and also evaluate the comorbidities and use of isotonic fluids if required. Intraoperative phase, the fluid administration during the surgery to maintain hemodynamic stability. The goal is to maintain the hemodynamic stability and the perfusion and replaces the losses like blood and insensible losses and use of crystalloids and colloids. The postoperative period, it's a management after surgery to support early recovery. The goal is to prevent the overload and hypovolemia, and also to monitor intake and output, and adjust the fluid based on the oral intake and laboratory findings. Coming to the basic physiology, the total body water constitutes approximately 60% of the body weight in men and approximately 50% in women. It is divided into intracellular fluid and extracellular fluid. The extracellular fluid again subdivided into interstitial fluid and plasma volume. This figure illustrates the same. Some of the principles behind the fluid responsiveness. Based on the Frank-Starling's mechanism, the venous return is equal to cardiac output. The more the preload, more the stroke volume. It is only effective if the preload stretches the cardiac myocytes. The concept behind the Frank-Starling's mechanism and the fluid challenge. The total blood volume is divided into unstressed and stressed volume. The unstressed volume is a volume that fills without rise in pressure, whereas stressed is an additional volume which causes both rise in pressure and distension of the vessel wall. The mean systemic filling pressure and the preload increases in response to increase in intravascular stress volume, thus increases the stroke volume. The aim of the fluid challenge is to expand the stressed volume so that we can significantly increase the stroke volume. This figure depicts the pre-fluid challenge and the post-fluid challenge. See, following the fluid challenge, there is increase in the stress volume, which significantly increases the systemic filling pressure. See the Frank-Starling's curve. So it shows x-axis ventricular preload and the y-axis stroke volume. Here, suppose if you give an adequate fluid challenge at point A, so it will increase the stress volume and also subsequently increases systemic filling pressure and preload, that increases the stroke volume. They are called as fluid responders. And if you give inadequate volume at the same time, it never increases the systemic filling pressure and also preload, thus they are considered as non-responders. Coming to the evolution of fluid management, we have different strategies of the fluid therapy like liberal, restrictive, goal-directed therapy. The liberal is the administration of a large volume of fluids, assuming hypovolemia and due to fasting preoperatively and third space losses intraoperatively. The total volume transfused is more than 5 liters. Whereas in restrictive, it minimizes the overload, reduces the transfusion requirement, and avoid replacing the urine output and third spaces. The volume transfused is less than 3 liters. Gold rate therapy targets the cardiac output and the oxygen delivery with the help of dynamic monitors. The zero balance GDT, it's avoid both overload and deficits. The fluid management tailored volume across perioperative phases. Some of the myths and facts of liberal fluid strategy. The surgical patients are hypovolemic due to fasting. So the fact is the blood volume remains normal even after prolonged fasting. The large volume needed to replace third plus, but the third plus loss is often exaggerated and it's a poor evidence-based. The liberal fluid improves the outcome. With limited evidence to support the use of liberal fluid strategies in surgical patients. Coming to the restrictive fluid management, it's a standard practice in various aim to reduce the intraoperative blood loss and need for blood transfusion. The key protocols of restrictive fluid regimens are, the blood loss is replaced with the colloids of 1:1 ratio and the crystalloids of 1.5:1 ratio. The intraoperative third space loss or urine output is generally not replaced, and the preoperative fluid loading is typically avoided. The use of vasopressor intraoperatively. Some of the difference between the liberal and the restrictive fluid regimen. In the liberal fluid regimen, induction phase, the total volume of fluid transfused is 10 ml per kg, whereas in the restrictive fluid regimen is maximum 5 ml per kg. The intraoperatively 8 ml per kg is the liberal fluid regimen, whereas for restrictive fluid regimen is 5 ml per kg. The postoperative fluid infusion is 1.5 ml per kg per hour, whereas restrictive is 0.8 ml per kg per hour. The restrictive regimens are now standard in many ERAS protocols. They are especially beneficial in patients with cardiac risk and renal vulnerability. Coming to the goal-directed therapy. It focuses on optimizing the cardiac function and oxygen delivery during intraoperative period. The aims to target the cardiac output of 4.5 liters per minute per meter square and oxygen delivery of 600 ml per minute per meter square. It also employs the monitoring technique to assist clinicians in administering fluids, vasopressors, and inotropes effectively. Zero balance GDT approach. Here in the preoperative phase, only clear water and carbohydrate drink 2 hours prior to the surgery. This is considered as preoperative zero balance. Intraoperative 12 to 18 ml per kg per hour with required blood transfusion as needed. The postoperative crystalloids 1.5 ml per kg per hour until the oral intake resumes without any blood losses. Here no advanced monitoring is required. Some of the complication of preoperative fluid management is hypovolemia and hypovolemia. The hypovolemia can cause pulmonary edema, which impairs the gas exchange and decreases oxygenation, which leads to prolonged ventilation. And tissue edema can delay the wound healing and increase the chance of infection. Coagulopathy due to dilution of clotting factors and increased bleeding risk, and prolonged mechanical ventilation with respiratory compromise. And some of the iatrogenic complications like infection, anemia, and prolonged hospital stay. Complication of hypovolemia. Due to prolonged hypotension can lead to organ hypoperfusion and acute kidney injury, myocardial ischemia, respiratory issues like decreased oxygen delivery and increased risk of hypoxia. Splanchnic hypoperfusion correlates postoperative nausea and vomiting and paralytic ileus. The impaired wound healing due to poor tissue perfusion and immune dysfunction due to increased risk. Increased hospital stay due to little recovery and other complications. Monitoring techniques. The monitoring of intravascular volume status is an essential step in appropriate fluid management. Some of the standard monitors like blood pressure, pulse rate, ECG, and peripheral oxygen saturation and urine output. The pressure detects the hypotension and also the trend analysis. The pulse rate, tachycardia can indicate hypovolemia, whereas ECG shows ischemia, arrhythmias, and oxygen status with the help of peripheral oxygen saturation. Urine output is a rough marker of perfusion, not always reliable. Coming to the advanced monitoring, central venous pressure, it's a static preload indicator and it has a limited accuracy. Pulmonary artery catheter, it's an invasive procedure and comprehensive. It measures cardiac output, pulmonary pressure, and mixed venous oxygenation. Some of the dynamic monitors like pulse pressure variation, it's a dynamic preload indicator useful in ventilated patients. Stroke volume variation assess the fluid responsiveness. Systolic pressure variations, another dynamic index for volume status. Transesophageal echocardiography is a real-time cardiac function and volume assessment. The esophageal Doppler measures the aortic flow and calculate the stroke volume. Some of the biochemical parameters like lactate level, it is a marker of tissue hypoperfusion. The base deficit and excess reflects metabolic acidosis and alkalosis. The dynamic indices outperform the static ones in predicting fluid responsiveness. The transecography and the Doppler offer real-time insights and are increasingly used in high-risk surgeries. How to navigate the fluid in perioperative period? The strategy is no longer recommended. Administering a fixed fluid preoperatively, which ignores the patient's vulnerability and risk of dehydration. Replacement of crystallite 3:1 ratio in the blood loss leads to interstitial edema and poor volume efficiency. The increase in the depth of anesthesia intraoperatively, BIS index less than 40 can cause vasodilatation, hypotension, and increased needs of artificial fluid. The preloading large volume before neuroaxial blockade may cause hypotension and fluid overload. Coming to the goals of perioperative fluid therapy, to maintain and correct the balances by addressing the dehydration, hyperolemia, and redistribution. Also stabilizes the plasma composition like electrolytes imbalances. Support circulation may require vasopressors or inotropes in addition to the fluids. Ensure oxygen delivery by optimizing the cardiac output and hemoglobin concentration, which coordinates the oxygen therapy. How the GDT shift past to present? The early practice, the liberal fluid therapy with outcome of complication like pulmonary congestion, edema, and poor healing, and minimal fluid usage, risk of acute kidney injury. And gold age therapy improves the hemodynamic stability with fewer complications and longer, reduced length of stay. Choice of fluids, we have crystallites and colloids. The normal saline has a more content of chloride that is a risk of hyperchloremic acidosis, interstitial edema, and decreased renal perfusion, the chance of acute kidney injury. Ringer lactate or acetate have a physiological concentration of chloride, which is more physiological, decreased renal risk, and preferred in most surgical settings. Colloid solutions, the sodium and chloride content is variable. It's an effective volume expander. The caution in sepsis and renal dysfunction. Avoid excess saline linked to acidosis and acute kidney injury. The balanced crystallites are safer, more physiological. Colloids may be useful in hypovolemia but requires careful selection. Encourage early oral intake, preoperatively and postoperatively. It improves gastrointestinal motility, wound healing, and patient's comfort. Intravenous fluids should be minimized once the peroral is tolerated. According to the NPO guidelines, the ASA guidelines says the no solids for more than 6 hours before surgery. The clear fluid allowed up to 2 hours preoperatively. The evidence-based practice, the preoperative oral hydration decreases the gastric acidity, improves comfort, and does not increase risk of aspiration. Some of the MRI studies confirms the safe gastric emptying of clear drink within 2 hours. Canadian European guidelines also encourages the preoperative hydration along with the GDT. Some of the impact of carbohydrate drink preoperatively. It reduces the postoperative nausea, vomiting, and study findings decrease usage of antiemetic drugs in post-laparoscopic cholecystectomy, and metabolic improvement. It maintains anabolic intraoperatively and decreases the protein breakdown. It boosts the insulin sensitivity and enhances the comfort of the patient. Intraoperative fluid management. The intraoperative fluid therapy must strike balance both hypovolemia and fluid overload, which are harmful. The modern practice focuses on flow-based metrics, that is cardiac output and the stroke volume, rather than static pressure readings. Additionally, the traditional concepts like third space laws are being challenged by newer evidence. The U-shaped curve of the two extremes, hypovolemia, hypervolemia with their complications. The intraoperative stability and perfusion. So why the flow matters more than the pressure? Here the blood pressure may be normal despite a poor perfusion. It's not a reliable sole indicator. The cardiac output directly reflects organ perfusion, and it's a key target in gold array therapy. The stroke volume indicates the volume responsiveness, which guides fluids and inotrope use intraoperatively. The GDT improves the stability by avoiding the hypotension, and also it combines inotropes along with the fluids with the help of dynamic monitors intraoperatively. Rethinking of intraoperative fluid losses. So avoid over-replacement based on mythical third space losses. The focus on actual measurable losses like evaporation, bleeding, and use of functional monitoring to guide therapy. The wound evaporation can be significantly reduced with warm fluids and coverage. The laparoscopic evaporation, the dry gas insufflation may contribute the fluid loss, but needs research. Third space loss is a mythical concept based on flawed methods. No evidence supports the existence. Post-operative fluid management. The post-operative oral hydration is the game changer. Some of the benefits of oral hydration post-operatively: it enhances the gastrointestinal function, decreases the paralytic ileus, and improved wound healing due to better tissue perfusion and oxygenation, faster discharge, and better patient experience with decreased discomfort, anxiety, and immobility. The protocols now recommended discontinuing IV fluids once the oral intake is tolerated. Early per-oral hydration is a cornerstone of ERAS protocol. Some of the trials on fluid regimens, the Relief, Optimized 1 and Optimized 2, they all favors towards the GDT, and some of the results are in due. So rethinking of oliguria, the traditional view is oliguria is due to hypovolemia. It's not always true. It may reflect vasopressin release intraoperatively and postoperatively. The urine output less than 0.5 ml per kg per hour may be normal in postoperative period. The correlation with acute kidney injury. Study shows no direct link between the oliguria and renal failure. The fluid overload, so fluid replacement due to oliguria can lead to acute kidney injury and edema. The threshold of less than 0.3 ml per kg per hour may warrant attention in major surgeries. The perioperative fluid management is a trifecta. The effective preoperative fluid management requires phase-specific strategy that integrates physiology, monitoring, and patient-centered care. The trifecta model, that is preoperative, intraoperative, and postoperative phases, ensures continuity and precision across the surgical journey. This trifecta aligns with the ERAS principle, promoting a faster recovery, fewer complications, and improved patient satisfaction. This is a trifecta model. Preoperatively should focus on per-oral hydration with a complex carbohydrate before 2 hours, and intraoperative gold-rated therapy to optimize the perfusion and avoid complications. Postoperative minimizes the IV fluid and adopt the early per-oral intake to better GI motility and wound healing and decrease length of hospital stay. Summary: fluids are medications, titrate with intent, not formulas. The GDT improves outcome by optimizing flow, not just pressure. Per-oral hydration is better than the IV fluids for long-term benefits and recovery. Avoid chasing urine output blindly. Focus on signs of hypoperfusion. Individualized fluid strategy reduces complications and hospital stay. Restrictive and GDT approaches outperforms the liberal strategies in most of the surgical settings. The updated fasting guidelines support the safe preoperative hydration with carbohydrate drinks.
Thank you very much, Dr. Anil. And that was a great updated view of a rapidly developing science, that is the science of perioperative fluid management. For the audience, the discussion will be at the end of the first session. So we'll move on to the next speaker.
Thank you.
Thank you, Dr. Shivakumar KP, for that insightful presentation. All speakers kindly submit your presentation at the preview area.